Welcome back to part 9 of our 15-part Interventional Radiology Coding Masterclass. Today, we are diving deep into our explainer titled Into the Vessels, How to Determine Arterial Branch Orders. If you're a medical coder, you know that vascular coding can sometimes feel like navigating a maze blindfolded. But don't worry, we're going to decode these classifications step by step and figure out exactly how to trace those first, second, third, and beyond third-order arteries. Let's get started. Here's a quick look at our agenda. We'll start with a brief refresher on interventional radiology, classify the procedures, explore the vascular families, and then we get to the really good stuff, the arterial classifications and real-world clinical examples of tracking catheter pathways. It's a macro to micro roadmap, so let's dive right in. Section 1. Intro to Interventional Radiology. We just need to take a quick second to set our baseline here, understanding exactly what IR is and how it compares to standard surgical environments you might already be used to. There's a pretty sharp contrast between traditional surgery and modern IR techniques. Same-day surgery usually involves open or laparoscopic approaches in an OR under general anesthesia. Interventional radiology, that's a completely different ballgame. It relies heavily on percutaneous approaches, meaning literally through the skin, using needles and catheters guided by real-time imaging. It minimizes trauma, which means much faster recovery for the patient. So, to really grasp IR, we have to think about minimally invasive surgery, or MIS. We are avoiding large cuts. Instead, physicians use tiny incisions, specialized tools, and image guidance to see exactly what they're doing inside the body. It's like threading a needle in the dark, but using real-time imaging as your flashlight. Just remember, all IR procedures are minimally invasive, but not all minimally invasive surgeries fall under IR. Section 2. Classifying IR procedures. Now let's zoom in. The absolute first step you must take when looking at an operative report is splitting the procedure into one of two highly distinct categories. We have to differentiate between what's happening inside the blood vessels versus what's targeting other anatomical structures. Vascular IR is all about the plumbing, treatments designed to restore or improve circulation in the blood vessels. Non-vascular IR focuses on everything else, organs, tissues, or tumors outside that vascular system. Before we can even think about branch orders, we have to know we're in the right neighborhood. Looking at these examples, you can really see the split. Stent placements, angioplasties, embolizations, you are firmly in the vascular category. But if the doctor is placing a drainage tube or doing a needle biopsy of a mass, that's non-vascular. Let's test this with a quick scenario. Imagine a physician performs a catheterization injection for an antegrade nephrostogram and a ureterogram. Based on what we just talked about, which bucket does this fall into? Take a second. What anatomy are we dealing with here? If you guessed non-vascular, you hit the nail on the head. Because this procedure targets the kidney, which is what nephro means, and the ureter system, it is absolutely non-vascular. Always let the anatomy guide your classification. Okay, Section 3. Diagnostic versus therapeutic IR. Once we know we're in the vascular realm, we have to determine the actual intent of the procedure. Why is the physician in that vessel to begin with? The human vascular system is an incredibly complex, sprawling web. Sometimes we just need to navigate it to map out a problem, and other times we have to go in and actively repair it. The big takeaway here is figuring out, are we just looking or are we actively fixing? Diagnostic procedures are investigatory. We inject contrast dye to find diseases or blockages. Therapeutic procedures take it a step further to actually treat the condition, like blowing up a balloon in an angioplasty to widen a narrowed vessel. Section 4. The vascular families. This is where the mapping really begins, and it's the foundation for figuring out our branch orders. Think of these as the three main highway systems in the body. You've got the venous family, bringing blood back to the heart, and the lymphatic family managing fluids. But today, we are hyper-focused on the arterial family, which carries blood away from the heart. In this family, the aorta acts as our starting parent vessel, basically the main trunk of our vascular tree. Section 5. Arterial family classifications. Grab your notes, because this is the core concept of today's lesson, determining exactly how these arteries branch out and how we classify their order. Let's start with core concept 1, first-order arteries. A first-order vessel is any artery that arises directly from the aorta or your starting parent vessel. For example, vessels heading up toward the head and neck, like the left common carotid or the left subclavian, those branch right off the aorta. So boom, they are first-order arteries. It's literally the first exit off the main highway. Now let's look at the abdomen and lower extremities, because this perfectly illustrates core concepts 2, 3, and 4. If an artery branches directly off the aorta, like the celiac trunk, the superior mesenteric artery, renal arteries, or common iliac arteries, those are all first order. But what happens when we branch off a first-order vessel? We get a second-order artery. For instance, if the common hepatic, splenic, or left gastric branches off that celiac trunk, those are second order. Same goes for the external or internal iliac branching off the common iliac. Take it one step further. An artery branching off a second order is a third-order artery. Think of the proper hepatic or gastroduodenal branching off the common hepatic. And finally, core concept 4. Anything branching distally beyond that third order, like the right or left hepatic branches or the cystic artery, is simply categorized as beyond third order. It's just tracing the branches of a tree. Section 6. Clinical catheterization examples. Now let's put this practical tracing methodology into practice and track a catheter tip path from the aorta outward. By mapping the physical steps, we can vividly visualize the journey. In this scenario, the physician accesses the common femoral artery, threads a catheter up, and identifies the renal artery for an aortogram. Because the renal artery comes directly off the abdominal aorta, what order is it? Yep, that's right, a first-order selection. Let's trace another one step by step. The catheter starts in the right femoral, goes up into the abdominal aorta, then crosses over into the left common iliac, which is a first-order branch. But they don't stop there. They advance even deeper into the left superficial femoral artery. The physician is actively tracing the pathway and selecting more distal branches of the vascular tree. And here is the absolute golden rule for medical coders. You code for the final, most selective destination of the catheter, even though they passed through earlier branches. Because the catheter ultimately landed in the left superficial femoral artery, that is the only placement you code. The final placement automatically bundles those lesser, earlier selections along the way. You don't code the first and second order stops if your final destination is third order. It really forces you to read operative reports with a totally different level of precision. Calculating that exact branch order is absolutely crucial. Well, that wraps up our summary on determining branch orders. Next time, in Part 10, we'll be tackling CPT code ranges and the diaphragm roles, specifically coding above versus below the diaphragm. You won't want to miss it. Thank you for watching and keep learning with Decode Healthcare with Harshal.